So I grew up in Maryland, and both of my parents were actually scientists. So I grew up admiring them, the work that they do, and envisioned myself following in their footsteps to become a scientist as well. Through my youth, I did have some personal experiences with family members, unfortunately suffering from cancer, often having very good outcomes, in part due to therapies on clinical trials with newer and improving therapies at the time. Understanding how the body works and how cancer unfortunately arises provides immense insight into caring for patients and designing our future therapies against those cancers. So for example, in the 80s and 90s, when lymphomas were being diagnosed at the time, essentially a pathologist said, how big or small are the funny looking cells that I see under a microscope? Whereas now we're really entering an era of precision medicine where many complicated tests are performed on patients' biopsies to make sure that diagnosis is very precise, as well as to identify therapeutic vulnerabilities, meaning how can we pick the right therapy for a patient's own cancer, not just that cancer in general across the population. There are new immune therapies where patients' own immune cells can be taken out of their body, genetically manipulated and given back to them. They're called CAR T cells, like little heat-seeking missiles, to go find that target on the tumor cells and fight those lymphoma cells. And so the same thing that we use as the marker to make the diagnosis is a really convenient vulnerability of the tumor to being attacked. I really love science, and science not only is great for understanding the world around us, but for providing knowledge and insight into how to design new therapies for cancer in general. I think one of the things that patients should always ask their oncologist when they first meet them is what we call the natural history is of a certain condition. And by that I mean, how quickly did it come to be? Have I had this for months, years, days, perhaps on the other end of the spectrum? What does the next few weeks of my life look like while we're making a plan? Am I at risk of getting sick? Or is this something that we can take our time addressing? And I think, it's not only the patient's job to speak up for themselves and advocate for their own priorities, but also the doctors to create an environment that's conducive to the patient speaking up and being honest with their providers and not afraid to say that, you know what, doctor, I have a wedding coming up at this time point and I want a treatment plan that allows me to be in this type of shape on this particular date. Or instead to say, I am a professional violinist and any compromise in my ability to do that when it comes to side effects is not tolerable. And so I need a treatment plan that accommodates that trade-off. So avoiding something we might call peripheral neuropathy in that context. Our job as doctors is not just to translate what's on a website or a textbook and just tell the patient that information. It's to care for the patient. Every patient is different, and so meeting them where they are, getting to know them is really, really important. I actually bring a clipboard with white printer paper into the room with me for every new patient and tell them that I'm going to draw and write some stuff for them for them to take home with them. Because I find that the amount of jargon involved in cancer care can really be overwhelming. And I really don't think it's the patient's jobs to worry about taking notes when I'm conversing with them. I'm glad if they do, and I'm happy to work with them to do that. But I feel also that it's my job as the expert in the jargon to write down the most essential terms for them, what they should focus on, what they should not have to focus on, and to really give them sort of a schematic of what they have, where we're going to go from here, and what the sort of plans would entail in terms of other workup that's needed, some details about prognosis, as well as what sort of therapeutic options there are, so that they're not worried about are they remembering one nuance or another from the conversation. I have patients from residency and fellowship when I was developing that technique who still have their few pages of notes that I wrote for them folded up in their purse 3-4 years later, and they add to it and staple things onto it as their course proceeds. I really enjoy all aspects of patient care. I think when we meet a new patient in the clinic, I think that oncologists have to realize that sometimes that might be that patient's the worst day of their life so far, being told that they have a cancer and here is the typical prognosis for that situation. It's hard to turn a bad situation into a good situation, but a clear situation should often be the target. How do we provide clarity to patients in terms of understanding that who their team will be, what that team's roles and responsibilities will be, what the next steps will be, and when updates to that plan might be made in the future in terms of picking a therapy, seeing how well that therapy is working, and then regrouping thereafter. And so I take a lot of pride in being able to provide that clarity to patients. Oftentimes, especially in lymphoma care, where many of our conditions are curable, when a patient's 5, 8, or 10 years out from their initial diagnosis and it's never come back, I let the patients fire me. That's okay. They can say, I'll call you if I need you, and in all honesty, doc, I hope I never see you again. And that's a really good time in my journey with them.